Dr. George left me about 5 minutes, I think, to go through all of adjuvant and first-line therapy options, but we're going to do our best. So these are just a few disclosures, and our objectives today are to review our current and possible future treatments to reduce kidney cancer recurrence after surgery, something called adjuvant therapy, and also to outline our treatment options and approaches for initial treatment of metastatic kidney cancer. So let's start with a case. So we'll discuss a 58-year-old male with a history of hypertension or high blood pressure who developed right flank pain and microscopic hematuria, blood that's seen in a urinalysis test. He's a non-smoker, has a normal body mass index, no family history of cancer. And they get a CT scan that shows a 7.5 centimeter right upper pole kidney mass, no abnormal lymph nodes, no other sites of disease. He had a CT scan of his chest as well that was normal. So he undergoes surgery, so a right nephrectomy. The pathology shows clear cell renal cell carcinoma, as Dr. George mentioned, the most common type of kidney cancer, measuring 7.8 centimeters. The good news was the surgery showed clear margins, meaning none of the areas of the cancer looked to be stretching outside of what was removed, 2 negative lymph nodes. There was some unfortunate news. There was a higher grade, so a grade 3. There was evidence of lymphovascular invasion in the tumor. There was necrosis present, as we saw on the picture of a tumor earlier. And there was also evidence of renal vein invasion, making a T3A tumor. His final pathology stage was stage 3A. So it's important to know what prognosis is for this patient. So there's several different ways that we can estimate that, but somewhere around the range of 40 to 58% chance of a recurrence of his kidney cancer in the next 5 years. Overall survival was 67 to 76%, depending on which estimator was used. And then these are a couple of charts that kind of show how that recurrence risk changes over time, as well as overall survival. So that leads us into what is adjuvant therapy and why does it matter? So adjuvant therapy is treatment given after kidney cancer surgery. So this is just a schematic that shows, similar to this patient, a diagnosis of renal cell carcinoma, undergoing surgery, and then a decision to be made about does that patient move on to surveillance, meaning no additional treatment planned, but monitoring with CT scans and lab work and office visits, or do they move on to adjuvant therapy, which is what we'll discuss further. The goals of adjuvant treatment are to reduce the chances of a recurrence, improve chances of survival long term, and also to minimize toxicity. And that's the balance that we play with treatment. So the standard of care for adjuvant therapy is with pembrolizumab. And this is a breakdown of the National Comprehensive Cancer Network guidelines that show right here, based on stage 2 disease, we have upfront surgery being the most common approach, and then a question of should we undergo surveillance or should we consider pembrolizumab or immunotherapy treatment as part of adjuvant therapy, or moving on to surveillance, often for non-clear cell histologies. And as well for stage 3 disease, again, surgery being the upfront treatment that's preferred. And then in all stage 3 patients, generally, there's a preference for adjuvant therapy with pembrolizumab. So this is the major study that told us that there's a benefit to using pembrolizumab after surgery. And we won't go through all of this in painstaking detail, but this has a list of what type of patients were included in that trial. And essentially, it was patients who been determined to be at a higher risk of recurrence after surgery. Patients who had stage 3 disease, for example, patients who had stage 2 disease but had certain features that clearly put them at higher risk, particularly things like having a high grade 4, or sarcomatoid disease were included. And those patients were randomized in the study to either receive a year's worth of immunotherapy with pembrolizumab or to be given a placebo treatment and essentially on the surveillance pathway. So what we found was that by using a year of pembrolizumab, patients had improvements in their recurrence rates. And the breakdown here, let me see if this, I'll be able to. So this top line being the patients who received the Keytruda or pembrolizumab, You can see the rates of recurrence were better at a year, at 2 years, 3 years, and 4 years. So still not perfect, but a better number to see than compared to patients who did not get treatment. And this was essentially seen for the most part across all groups. And we won't go through the breakdown, but this is an analysis that looks at individual different types of kidney cancer across the entire trial. And for the most part, you can see that the majority of these show that these dots are all, for the most part, on the left side, meaning that patients, for the most part, did benefit from pembrolizumab. There's also now, after the most recent update, an improvement in overall survival. And this is, again, one of our major goals with adjuvant therapy is following patients over time and seeing by doing this extra year of treatment, are more patients living long term? And based on the results from this trial, it looks like we do see that, especially when we get out to the 4 year timeline where we have 91% of patients still alive compared to 86. And this was a significant difference statistically. And another breakdown based on subgroup analysis as well that again favors the treatment with pembrolizumab. So then that begs the question, is adjuvant therapy with pembrolizumab for everyone? The pros of treatment: we improve kidney cancer outcomes, relapse rates, overall survival across populations of those patients who are intermediate high or high risk disease. It's usually well tolerated treatment that's for a defined amount of time. It's a year and then you stop. There were no treatment related deaths previously seen in the trial. But there are cons to treatment. It's not possible to know with 100% certainty, patient to patient, who really benefits from treatment. Some patients in this study or in real life may not have had recurrence even if they didn't have treatment. And there's others who may recur regardless of whether they received the treatment or not. And although it's uncommon, some side effects can be severe. About 8% of patients in the study needed high-dose steroids and 12% were hospitalized. And occasionally, some of these side effects can be permanent. It does require more frequent clinic visits. There's more lab monitoring. You're seeing your physician more often. So it does have some impact on quality of life for patients who are on treatment. I think the bottom line takeaway is that adjuvant treatment with pembrolizumab represents a major advance for selected patients with clear cell renal cell carcinoma, but it's not a one-size-fits-all decision. It requires balancing recurrence risk, potential for cure, and toxicity through shared decision-making between patients and their oncology team. Since we've had that data, there's been other trials that have been done trying to see, can we improve on those numbers even more? This was a recent trial called the LIGHTSPARK-022 trial that's trying to evaluate adding in another medicine called belzutifan to pembrolizumab to see if we can get those numbers even better. We don't have data just yet, but we have had an announcement that there was a positive disease-free survival benefit from that. So we're still waiting to see additional information there. So to move forward for initial treatment of metastatic kidney cancer, some overview, and we've heard a little bit of this already, about 15% of patients with renal cell carcinoma present at diagnosis with metastatic disease. Clear cell RCC makes up the majority of cases, as Dr. George mentioned. Most patients are living for years. Some patients have long-term durable treatment responses with significant improvements in outcomes over the last decade. Patients who do have limited sites of disease, which we call oligometastatic disease, sometimes treated with surgery or radiation with or without starting systemic therapy or medicines to treat kidney cancer. And combinations of medicines called tyrosine kinase inhibitors or TKIs, which are pills, targeted treatments, and immunotherapy, drugs like pembrolizumab and a few other immunotherapy options have become the standard of care for initial systemic treatment. This is a little bit of an overwhelming cartoon, maybe for some reasons, but it is a nice breakdown, I think, of all of the different ways that we approach kidney cancer treatment. You might see down at the bottom to the a credit to Dr. Rose, who you're going to see here in just a minute. This was published in, I think, JAMA, I believe, in 2024, but a really nice schematic that shows that this is a complicated mechanism of how to approach kidney cancer, but we really have lots of different targets, and the medicines that we use are aimed at trying to approach it from several different sides. And I included this slide, and I hope it's not too overwhelming either, but just to show a little bit of how we've made changes over the past decade. So to break it down a little bit, this chart on the left is looking at how patients were treated for kidney cancer, metastatic kidney cancer, from the years 2011 to 2018. And you can see that the vast majority of patients are all this sort of bluish purple color. And that was with TKI single treatment. Again, that's pills. And there's a small portion of patients who were given immunotherapy, and then other treatments kind of make up a small portion down here. But the vast majority of patients were getting a single pill as their treatment. If we fast forward to this data collected since 2018, you can really see that we have options now. It's actually a smaller portion of patients who are getting that TKI monotherapy, a decent chunk who are getting both combination of two different types of immunotherapies, and this is the PD-1 inhibitor and CTLA-4 inhibitor here. Another chunk who are getting a combination of PD-1, PD-L1, which is immunotherapy, and a TKI, and then single agent immunotherapy here. So this has gotten, I would say, more complicated, but really the big takeaway to me is that we have better options now. And this is a decision, that is made between you and your cancer team about which approach do we take, because it used to be more of a one size fits all. That's not where we're at now, which is a good thing. So Dr. George went through a little bit about how we think about risk factors and how we put patients into different categories to better understand their prognosis. I'm not going to go through this in too much detail, but essentially, when we are looking at patients for the first time and looking through their history, we assign a risk score that helps guide us and patients in terms of what their treatment should be. And again, I mentioned it's gotten complicated. It's not this is what you do if you're diagnosed with metastatic kidney cancer, and not always 100% straightforward. And this is the chart, again, from the National Comprehensive Cancer Network guidelines that tells us about all of the different options that we have. I tried to highlight here in this color, these are the pills. These are TKI therapies. And these are our immunotherapies. And so you can see the breakdown where, for the most part, the most common treatment that most patients will receive is going to be some combination of two different treatments, typically with a TKI pill treatment as well as an IV immunotherapy treatment, although certainly double immunotherapy is an option as well. And sometimes still, we do occasionally use single agent TKI therapy. This chart breaks down all of the different trials and studies and data that help lead to the different approvals for our options. And again, so I tried to keep those same highlights to understand. Two blue here is two different immunotherapy medicines. And then the rest of these are typically a combination, of immunotherapy and TKI pills. And we won't go through all of these, but I think, from a patient perspective, this administration column is an important way to think about your treatment. Again, so our double immunotherapy option of ipilimumab and nivolumab is IV infusions every 3 weeks, 4 times, and then every 2 or 4 weeks. These others are some combination of an IV infusion, again, sometimes every 3 or 6 weeks, every 2 or 4 weeks, every 3 or 6 weeks, along with a pill that's typically taken daily or twice daily. So how do we choose? So let's go through an algorithm of newly diagnosed metastatic RCC. First, we need to know about the histology, which Dr. George talked us through. And again, most common type being clear cell histology. We assess for risk, and for favorable risk kidney cancer, we assign and then look at the burden of disease. For patients who have a low burden of disease, sometimes we can even consider surveilling it or just watching it. Other times we may do something called metastasis-directed therapy, either surgery or radiation to all sites of disease. For higher burden patients, we then decide, is this something that's causing symptoms for the patient? Is it rapidly progressing? And if so, our most common choice will be that combination of immunotherapy and a pill. If not, it's an option to consider a double immunotherapy approach. And for patients who are not eligible or otherwise interested in immunotherapy, we do have the option for a single pill TKI, something like cabozantinib, sunitinib, or pazopanib. For patients who are intermediate or poor risk, again, we assess what is the burden of their disease and still consider whether we should do some form of metastasis-directed therapy with surgery or radiation. For higher burden patients, again, determining are they symptomatic, is it rapidly progressing, or do they have liver and bone involvement? And if so, typically we'll choose, again, a combination of immunotherapy and a pill with a TKI. If not, we have more of a choice, and it's a shared decision with the patient between considering double immunotherapy or the combination therapy with immunotherapy and TKI pill. And again, for patients who are either not interested or not eligible for immunotherapy, a single agent TKI, typically with cabozantinib, is an option. Non-clear cell patients are a smaller portion, still extremely important, but less data sometimes to guide us. And typically, what we prefer in this setting is if we have it available, is enrollment in a clinical trial. Otherwise, our treatment is typically tailored based on histology, disease burden, and shared decision making with the patient. Probably detailed, it's a little bit outside of our scope today. So as far as our takeaways from this talk, adjuvant therapy can help reduce the risk of kidney cancer recurrence after surgery. Pembrolizumab for a year is our current standard treatment for higher risk patients. For metastatic kidney cancer, combination treatments with a TKI pill and immunotherapy or double immunotherapy have significantly improved long-term patient outcomes. This treatment choice is based on disease and patient-specific characteristics, often requires shared decision-making both with your oncology team and with you for the right selection. And clinical trials offer access to new treatment options or approaches, help us make continued progress in giving patients longer, healthier lives.